This is a 65-year-old patient who presents with a history of ocular trauma occurring 40 years ago, which was previously neglected. He reports a significant and gradual decline in his vision in his right eye, and his vision right now is hand motion in front of his face. Upon examination under the slit lamp, I found a temporal corneal adherent scar accompanied by a peaked pupil and a very dense cataract. The trauma resulted in a full-thickness temporal corneal wound which has self-sealed due to the iris leading to the observed beaked pupil. Surprisingly, specular microscopy indicates a very low endothelial cell density in the right eye. Also, corneal pachymetry remains within normal limits. I discussed my treatment plan with the patient, which involves phacoemulsification with the pupilloplasty. I emphasized the guarded prognosis regarding the corneal condition and informed him of a potential need for corneal transplant surgery. There be any compromise to the cornea either post-operatively or at a later date. So now back to our case. After doing two paracentesis and clear corneal incision, injecting intracameral mydriatic agent to dilate the pupil, and staining the capsule as it's clear, it's very crucial step here is to use dispersive OVD to fill the anterior chamber to protect the back of the cornea, which is compromised already. Then, as you can see here, the capsular rhexis, I'm going very close to the edge of the pupil to achieve around 5 millimeter capsular rhexis diameter. Then, before doing the hydrodissection, slightly empty the anterior chamber from the viscoelastic, and it's very difficult to see the wave in case of dense cataract, but rotation of the nucleus is a good indicator that your hydrodissection is complete. Now the time for emulsifying this dense cataract. Actually, I prefer to emulsify this dense cataract using horizontal chop technique, but inside the capsular bag, not inside the anterior chamber, far enough from the back of the cornea to protect the compromised corneal endothelium, with multiple injection of dispersive OVD while chopping and emulsifying this dense cataract together with mechanical chop to minimize the ultrasound energy which could affect the corneal endothelium. As we can see here, emulsifying of this small piece. Also, it's very important to adjust the parameters to decrease the IOP as I'm using the Centurion phaco machine in this patient, and also try to avoid hitting the back of the cornea with the irrigation from the irrigation probe during the cortex removal, as we will see now. Now it's the time for cortex removal. It's also one important thing here is to remove all the cortex and don't leave any hidden cortex, because it will lead to post-operatively inflammation which could affecting also the back of the cornea. Here, injecting the cohesive OVD to forming the capsular bag and anterior chamber, I'm trying to release the incarcerated iris inside the inner lips of the scar. We should avoid stretching the iris too much, which could lead to iridodialysis. As we can see, there is a few bleeding at the angle. Now the iris is released and the pupil is rounded and everything is fine. It's the time for implanting a single piece hydrophobic IOL inside the capsular bag. As we can see now, the IOL inside the bag and the iris is released from the scarred cornea. Now removing the viscoelastic, also it's very important to remove anterior and behind the IOL and don't leave any viscoelastic to prevent the postoperative spike of the IOP, which could affecting also the back of the cornea. Then injecting myopol to constrict the pupil and doing very gentle stromal hydration, as we can see, and avoid overfilling of the anterior chamber. with the BSS by the end of the surgery, which could lead to high intraocular pressure postoperatively and affecting the cornea. Here is the patient on the next day. We can see the pupil is rounded and the cornea is almost clear despite of there is some stria in the cornea, as we can see. And the vision of this patient improved from hand motion to 20/100. And thank you for watching